Hi Prep team, today is 29th of November and I'm doing the INI CET exam questions for Obs and Gynae, I think. Alright. Hi, welcome back. And now we'll do the deliberations on the INI questions which came for obstetrics and gynecology this year. And as expected, there was representation of all the colleges. I could make out JIPMER, PGI, AIMS questions all way given as a good mix in this question paper. And let's see, we'll try and sort them out one by one. There were not many direct questions on Obs and Gynae. They were just 11s given to me. But some questions would have had their representation in medicine, some in pharmacology. I'm sure they're going to take a very good discussion on those. And for any doubts, you can always write to me. All right, so we'll start with the first question. A lady present in labor with breech presentation, which among the following is false? Now, when we talk about breech presentation, please remember breech presentation does not require a cesarean section always. In practice, many gynecologists are doing cesarean sections for a primary breech, and for anything to do with breech, they do a cesarean, which is wrong. All right, we are teaching you breech vaginal deliveries, we are teaching you maneuvers in your classes, and with the doll and the dummy, we have shown you so many times how to deliver a breech. It's not because we want you to do always a cesarean section. So even before I read the choices for this question, please understand, primary breech is an indication for giving a trial of normal vaginal delivery if there is a good tertiary setup and there is a good obstetrician who's trained in managing a breech vaginal delivery. So if that is present, we will give trial of breech vaginal delivery. Of course, we will counsel the patient, take a consent, and then do that. All right. So now with that background, let's see the choices. For breech delivery, continuous fetal monitoring should be done. Breech identified for the first time in delivery is contraindication for normal vaginal delivery. Breech delivery in hospital where emergency CS is available? Yes. Done in the presence of obstetricians experienced in performing assisted breech vaginal delivery. Well, a lot of things about this question is correct. So which one is false? Now, breech identified for the first time of delivery is contraindicated for a normal delivery. I think this is what is wrong, because when we say a patient is having breech, and that too in advanced labor, she's come to you in labor, that's actually a very good thing, because the breech has probably gone into the pelvis and she's come in labor to you. It's probably a good thing that, your doubt of trying to counsel her and then doing a breech and delivery, that insecurity is already taken care of because she's come in labor. So they've given a better question. They've told you that the patient is in labor. Then what do you do with the breech? I will deliver it. Of course, there should be an obstetrician. So the other three choices have already taken care of it. There should be a good setup, and there should be a good experienced obstetrician who should be taking care of this. So yes, the answer is B. Breech identified for the first time delivery is contraindicated for a normal vaginal delivery. That is a wrong statement. All right. And in addition to that, I wanted to tell you the indications for electronic fetal monitoring. EFM is electronic fetal monitoring. So yes, we will not do continuous electronic fetal monitoring for all the deliveries, because doing that, you will be picking up very, very small variations also. And, sometimes a bad connection in the apparatus also can give you a wrong reading. I'm not saying that always happens, but very small variations will get you very worried, and you may do more cesarean sections if you're doing continuous electronic fetal monitoring. So that should not be done. It has been proven that we should do it only for indicated cases like these, that when we're doing induction of labor with oxytocin and there is reported fetal heart rate variations, there is a prematurity, we are giving an epidural because epidural is known to cause some decelerations, meconium staining of liquor, antepartum hemorrhage, especially abruption. And one thing which I deliberately left for later is the malpresentations. So if there's a breech, I would do a continuous electronic fetal monitoring. All right. So answer for this question is B. We'll take question number 2 now. A midwife was examining a pregnant woman. Suddenly she noticed a prolapsed umbilical cord. What should be the next line of management? First things first, don't handle the cord. Do not touch the cord. Don't try to do anything with the cord. If it has come out of the vagina, then it is an instinct that all of us feel that we should push it back inside and it'll be fine. Your act of holding the cord and pushing it inside will cause vasospasm, and that will be detrimental for the baby's heart rate. All right, he will go into hypoxia. Do not handle the cord. I know a lot of you have been given the answer that replace the umbilical cord into the vagina. That's a wrong answer. Okay, so replace the umbilical cord inside the vagina is wrong. Trendelenburg position, well, there is a better position. Trendelenburg is not altogether wrong. Keeping a head low will help, but there are better positions to keep the patient in rather than Trendelenburg's. So I will mark this one also wrong. Inform the higher authorities, okay, inform your seniors to shift to the delivery room. Now that's, maybe the choices have not been recalled properly because most of you have sent this choice to me. So inform the higher authorities to shift the patient to delivery room. I would not want the patient to go to the delivery room. I would want the patient to go to the operation theatre rather, and fill the urinary bladder to elevate the presenting part and avoid cord compression. So yes, whatever you do, you should try and avoid cord compression. So don't hold the cord, don't handle the cord. Push the presenting part a little bit higher, because the cord might be stuck between the head and the pubic symphysis or head and the sacrum. So you can push the presenting part a little bit up. That will relieve the compression on the cord. You manually don't handle the cord. So pushing the presenting part up will help, in addition to trying to fill the bladder up, because once the bladder is filled up, then also the presenting part goes up. There's a classical teaching that when the bladder is too full, then the engagement of the presenting part does not take place. So we try to do that now. We try to fill up the bladder and push the presenting part up. So that actually is the answer to this question. And I'll try and give you the guidelines from which I've given you this answer so convincingly, because a lot of you thought that replacing the cord is the answer. Now these are the green top guidelines. We call them the GTG guidelines from Royal College of Obstetrics and Gynecology, and this is guideline number 50. And you don't have to read the guidelines, please. These guidelines are so many and they are so huge that it will be difficult for you to read those guidelines. I'm just mentioning them here so that you are convinced of my answer. That's all. So what is the optimal initial management of a cord prolapse in a fully equipped hospital setting? So preparation made for immediate birth in theatre, not in the labor room. There is insufficient data to evaluate manual replacement of the prolapsed cord above the presenting part to allow continuation of labor. This practice is not recommended. All right, it is given in black and white and bold actually. To prevent vasospasm, there should be minimal handling of loops of cord line. All right, reinforcement of what I said. Now, to prevent cord compression, it is recommended that the presenting part be elevated either manually, like I said, or by filling up the urinary bladder. Okay, so these are all the recommendations, and I hope you people are convinced of the answer which I gave you. And the position is the knee chest position or left lateral, with the head down and pillow under the left hip. The head down is not wrong. I said a little bit head low is okay, but it's better to keep the patient in knee chest or a left lateral position. So like I said, Trendelenburg position might have been a better, better answer than the other two choices which I ignored. But straight away, filling the urinary bladder is a good answer for this question, and the position is knee chest or left lateral. All right, so let's move on and see question number 3. Chancroid findings are. I think this was a skin question, but I think there was a lady who had chancroid and what was the findings, but I just kept the question the way it was given to me. So it's painful, it bleeds on touch, and it has school of fish appearance. Yes, these things you have been taught very well by your dermatology faculty. And groove sign is not here. You guys know this very well. The groove sign is seen in lymphogranuloma venereum, and in the lymphogranuloma venereum you see that if you see the inguinal ligament at this area, if you see, and of course if this is the perineum, so you can make out easily that the patient's lymph nodes might be enlarged above this and then below this. So this is the matted lymph nodes, which we call them a bubo also, right? So this whole arrangement of lymph nodes, the inguinal canal lymph nodes and the femoral group of lymph nodes, so this will look like two sausages up and below, and between that there is a groove. This inguinal ligament makes a groove. So that's a groove sign in the LGV, not in chancroid. Okay, so chancroid also, if you know, it has irregular edges and undermined irregular edges. You guys know the the architecture of the chancroid ulcer, and of course it is compared with the other ulcers like that of syphilis. That's we've dealt with that in one of the exam questions. You must see the other questions in the app. So we've dealt with that in detail. So undermining irregular ulcers are the chancroid and very painful ulcers. There's a picture of chancroid ulcer on a penis, courtesy the dermat faculty of PrepLadder, and this is how the ulcer looks like, and it has got these ragged undermined edges, if you can see. Okay, so let's move on and see question number 4. A pregnant female has cramps in legs. What suggestion will you give? So apart from giving her good rehydration, dehydration and electrolyte imbalance is something which is very commonly seen in pregnant women because somehow they drink very less water. So getting them rehydrated and giving them a good electrolyte solution, we can give them ORS. It is known to help a lot of women with their nocturnal leg cramps. But what is the position they've asked which is going to help? So when I think of the cramps in the legs, we mostly think of the cramps in the calf muscles. I think the question was of calf muscles, but since that was not given to me by all the students, I assume that it was cramps in the legs, and I'm writing calf just to tell you that this is what I heard. So let's see, I've got this picture from the internet from Wiki Commons, and if you see the calf muscle here, you know that the calf muscle is required for plantar flexion here at the ankle, and it also helps, it assists at least in the knee joint flexion also. So when the calf is contracting, it will cause flexion at the knee joint and flexion, the plantar flexion at the ankle joint. So to give it relief, we want the ankle to be dorsiflexed. Then we'll give rest to the calf, and we want the knee to be extended to give rest to the calf. So what is the action of calf? Opposite to that would give rest to it. So that's why I say dorsiflexion at the ankle joint and extension at the knee. So that's why my answer is A. So we'll go with this answer, and I've tried to give you the explanation for that. Let's move on and see question number 5. Of the Robson's classification, the 10-group classification system also that is called Group 1 includes. Robson's classification is something we have discussed as professors and as consultants of institutes where we are teaching. We have discussed about this, and we know that it's a process of audit. It's a process of auditing cesarean sections in a hospital, and what are the indications in my hospital, what is a common indication in that hospital, what is the common indication, and then all the hospitals together of Delhi, they get together and they present their data to the government or for research purpose. So doing audit of cesarean sections, the Robson's classification or the 10-group classification system is used. This was first used in the National Maternity Hospital of Dublin in Ireland, and that was 2013, and then it was accepted by WHO as a recommended way of doing audit in cesarean section. Now, audit in cesarean section, audit in obs and gynae is definitely a postgraduate topic and not a postgraduate entrance topic. That's what I feel. But things are, it is assumed that all the routine things you guys know very well. So that's why they are putting in questions like this. So yes, this is Robson's classification for audit of cesarean sections. And this is also known as the TGCS, 10-group classification system. In this, there are 10 subclasses, there are 10 categories. So what is the group 1? Group 1 is the nulliparous singleton who are undergoing spontaneous labor. So the answer is B. Now, let me show you, I'm just giving you the paper in which this study and this audit system was first published, and that is the International Journal of Obstetrics and Gynecology, and this is from the National Maternity Hospital of Dublin, Ireland. So the category 1 is nulliparous cephalic, single cephalic more than 37 weeks in spontaneous labor, and nulliparous single cephalic more than 37 weeks induced or cesarean before labor. So these are all the categories, all right? So the categories are here, and then this is the study groups, all right, of the number of studies which were done. Like in one study, it was seen that 146 patients out of 2040 were nulliparous single more than 37 weeks spontaneous labor women, like that. This is the studies, and size of the group is mentioned next. Now, these are all the cesarean delivery in group as a percent. So in this group 7.1, and you can see 100% women had a cesarean when there was abnormal lies, whether there was a previous cesarean or not. All these women in this group had cesarean section 100%. But the sixth column is telling you that in all these patients who had undergone cesarean section, which one is the major most contributor for the cesarean sections. So this is that column, and this you can make out the biggest contributor for cesarean section is actually the previous cesarean section. All right, so this is how the audit is done, and this is how we represent our data across many hospitals, and then we come to a conclusion how cesareans are done in various institutes. A little tough, but then it is there in your exam, so now you have to know it. Okay, so this is the information which I gave you earlier, that now WHO has proposed this as a global standard for assessing, monitoring and comparing cesarean delivery rates within and between healthcare facilities. Okay, question number 6. A 45-year-old female attends gynec OPD with a history of frequent Trichomonas vaginalis infection. She was advised for a pap smear. What is the role of the pap smear in this patient? Now, trichomoniasis is not a predisposing lesion for causing CS cervix. Please don't get confused that way. And we are not doing a screening of CS cervix. Absolutely, we are not doing that here. Definitely not, because when there is an infection, it's a contraindication to do a screening for CS cervix by pap smear. That you guys know very well. So we are not definitely looking for CS cervix. We are just trying to help demonstrate Trichomonas vaginalis infection. You can take that and play it on a slide, put some drops of saline, cover that preparation with a cover slip and look under the microscope, and you'll see motile trichomonads. All right, the flagellates, it's a flagellate, so when you put some saline and then put the cover slip, you'll see them moving under the microscope. You can see them very easily. We used to do this regularly. We never used the pap smear spatula. We actually used the cotton swabs. You know, the cotton swab, we used to take the secretions and do this same preparation. But you can use a pap smear taking instrument called the IR spatula also. It is just a way to get you a little confused. It's just that we are using the spatula for taking the secretions and plating them on the slide. That's the meaning of this question. So answer is to help demonstrate Trichomonas vaginalis infection. Answer is C. Okay, question number 7. Development of the recombinant HPV vaccine is based on which viral proteins? Now, smart question. We have always taught you that the E6 and E7 oncoproteins, these are the oncoproteins which are the agents which go ahead and cause the pathology of human papillomavirus. So the human papillomavirus needs the oncoproteins E6 and E7 to cause the pathology of causing abnormal cell division and abnormal cell forms and atypical cell forms. So these oncoproteins are required for the exhibition of the action of human papillomavirus. So they have not asked you this question. They have actually asked you which part of the viral protein is taken for making the vaccine. Okay, so the part of the virus which is the capsid, the L1 area, okay, the recombinant HPV vaccine is prepared from the purified virus-like particles of the major capsid L1 protein of human papillomavirus 16, 18 and all the other cancer serotypes which are known. Okay, so it is the major capsid L1 protein of HPV. So that's the answer for this question. Now, which group is shown in the image below? One easy question so that you people are not totally depressed with your exam paper. And this is the lateral grip. That's the easy one. And of course, when we put a hand on the, the fundus of the woman, when we put a hand here, it is the fundal grip. And this is the lateral grip, which is the, the second grip, like we say. And the first pollic and the second pollic are the pelvic grips. And the first pelvic grip, obviously, please remember, no more doubts on that. I've taught you in the obstetrics chapter also. The first grip is keeping your hand like this at the just above the symphysis pubis and trying to hold the presenting part and see what is in the lower segment and looking at the mother's face so that you know she's getting discomfort or not. Okay, the first pelvic grip is while facing the mother, and the second pelvic grip is facing the toes of the mother when you put both your hands on the above the symphysis pubis and see whether the presenting part is engaged or not engaged. And with this second pelvic grip also you can make out what is the second what is the part which is trying to come into the lower segment or which is in the lower segment. So there was this question which was asked long time back, that if I'm allowed just one grip of the fundal, lateral and the pelvic grips 1 and 2, if I'm allowed just one grip to know everything about the presentation and engagement and everything, which is that grip? That is the second pelvic grip. When you put your hands on the above the symphysis pubis and try to feel what is in the lower segment and whether it is engaged or not. So if you know it is the head and it is flexed or extended head, whether it is engaged or not, everything can be made out by the second pelvic grip. So if they ask you which is that one grip which tells you everything, it is a second pelvic grip. Okay, we'll take question number 9. A midwife was plotting a partogram for a patient in labor. Ideally, how much cervical dilation she must start plotting the graph? At what cervical dilatation ideally the partogram is started? When should we start plotting a partogram? Now this question was fairly simple a few years back and we all answered 4 centimeters even without batting our eyelids. So even without thinking once, because that is actually the answer which I want you people to write for this question. Now the problem is that there was so much discussion about this for the last 4-5 years in journals and in the WHO forum and the American College of Gynecologists recommendations. There is so much discussion about this that this made us think twice before we came to this conclusion of 4 centimeters. Those who written 4 centimeters, I hope you get the right answer. But the problem is that all exams, whether it is the the complete exam together for these or the NEET exam, they are not giving us the answers. If they start giving us the answers, life would be much simpler. You'll have to read more things, but at least you know what is the answers expected. What is the answer to this particular question which was difficult, but that's the answer expected. Next time at least you know that I can answer this and get the right marks. But that is not happening in exams, and we are starting I'm starting a chain of letters. I hope that you people also support this cause, that you must know the answers of all the exams which you are attempting. So let's come to this. The answer is 4 centimeters. Now there's a lot of doubt about this. Why? Because like I've taught you 4 centimeters. See, I've started plotting the partogram at 4 centimeters onwards. But let's see, what do the Americans say? Now, Consensus Committee of American College of Obstetrician Gynecologists and Society for Maternal Fetal Medicine has redefined active labor to begin at 6 centimeters. So when the active labor starts at 6 centimeters, then why should you plot before that? Okay, so that's what the Americans say. Now, this is what the WHO says, 2018, that cervical effacement and more rapid cervical dilatation from 5 centimeters until full dilatation for first and subsequent labors. So for them, active labor is this one. However, the duration of active first stage from 5 centimeters until full cervical dilatation. See, again, active first stage. So for them, active labor is 5 centimeters. That is WHO. I'll read more about what WHO says. We'll read from here. Plotting should commence from a cervical dilatation of 5 centimeters, which signifies the onset of active first stage of labor. Now, these are all 2018 WHO recommendations. So the problem is the Americans say 6 centimeters, the WHO people say 5 centimeters, but for all practical purposes, please try and understand, if a patient is 5 to 6 centimeters, there's hardly any labor left. And at 5-6 centimeters, if you've not seen active labor, then it's actually very late. At 5-6 centimeters, we know that the patient will deliver in a reasonable time, and if she does not deliver in that reasonable time, we'll go ahead and do a cesarean section. So I think it's pretty late to start a partogram, and that's why I answered what I answered. I have answered that it is 4 centimeters because that is what the good old teachers O'Driscoll and Dr. Friedman, these are the people who actually devised the partograph, and when they devised the partograph, they thought of 3 to 4 centimeters, and that's what I think we'll stick to for the time being, because traditional teaching is what is important. Now, to get you more convincing answer that it is 4 centimeters, it is what was taught. This is what doctors taught, that the labor starts going to a much more active phase of contractions and regular dilatation and regular descent after 3 to 4 centimeters. 3 centimeters, sometimes we are not using that anymore because a patient might still be in latent phase of labor. So 4 centimeters is a very practical definition. Now I called up all the institutes which I can't name here in this forum. I spoke to people who are at my level and I spoke to them. They are very senior people. Then I rang up Great Britain also. I rang up my friends who are consultants there and said, right now you can see my midwives here, they're sitting and plotting the graphs at 4 centimeters. So I convinced myself once more, just for the sake of answering you with conviction, that yes, the answer is indeed 4 centimeters. Active stage of labor, if they ask you, well, I will have to ask you to mark 6 centimeters if they ask you that, because Williams Obstetrics is saying that, and that is the book which is important, and that is the book which is considered as a Bible for references, and I cannot disregard that. So plotting, go with 4 centimeters, and active stage of labor, if they ask you, 6 centimeters. I think the answer should be same, 4 for active and 4 for plotting, but simply because 4 centimeters watch is practically used across the country even now. The recommendation of 6 centimeters, but it has not been put into practice. So I did a lot of research to come to this conclusion that we'll stay at 4 centimeters. Okay, all right. A lot of discussion on this happened. So let's move on and see question number 10. Which virus has the following pathophysiology and causes microcephaly in fetus? Now, the question actually is very simple. Which of the following viruses causes microcephaly in the fetus? And I think apart from parvovirus, all these three will cause microcephaly. But you know, the answer which I think they're looking at is at Zika virus, because you know, the major problem with Zika virus are the problems of the CNS and the head. But rubella, CMV may have, or is one of the inclusions in the syndrome is microcephaly. So that logic makes me answer Zika virus. So the Zika virus syndrome includes microcephaly, lissencephaly, ventricomegaly, intracranial calcifications, ocular abnormalities, and congenital contractures. It's the only virus which is mosquito-borne and it's known to cause congenital anomalies. Virus which is mosquito-borne and known to cause congenital anomalies. That is the first instance of something like that happening. Mosquito-borne virus infection which causes congenital anomalies. Because if you look at the virus which is troubling us right now, COVID, that does not cause anomalies. All right. So mosquito-borne virus which is causing anomalies is Zika. Now, parvovirus, B19 virus, which causes erythema infectiosum or the fifth disease and the slap cheek appearance. This can lead to anemia, which is the primary fetal effect. So that is not the answer to this question. Rubella can cause microcephaly. So can cytomegalovirus cause microcephaly. But I think all about CNS involvement is mentioned in Zika. So I think the answer to this question is C, Zika virus. Okay. So, and that's something which I've also taught to you in the, I know almost all the questions which came we have discussed, but I think the question on the position on the leg and the question of, chancroid, they are the questions which were not directly to my specialty. Rest everything we have discussed in our discussions earlier on. Which is the position of the fetus in the image shown below? So, if you can see this image, you can make out this is the pubic symphysis and this is the sacrum, and you can see the the broader part of the head is here. So the occiput is here. So this is the right of the patient and this is the left of the patient, and this is anterior and this is posterior. So right occipito anterior. So very simple, right occipito anterior is the position of this, and there was a lot of discussion about what is the most common position. Yes, all positions, all heads are left occipito transverse to start with, but yes, eventually they become left occipito anterior and then they deliver. So there was this discussion, and in our setup, in Indian setup, lot more LOA is seen. That's why there was this confusion. But if you have to mark one, please go ahead and mark left occipito transverse, all right, as the commonest position. And this position is right occipito anterior, right. And occipito posterior is the most common malposition, and that's the one you people should be reading if you're not read so far. It's on that they regularly ask questions. Occipito posterior will deliver. Okay, so these were the questions which came in this exam, and I feel that there was a lot of controversy regarding the the partogram question, and some discussion always happens about the questions which keep coming in the exams. But I hope you do take the carry-home message which I've given you in detail. And anything else, any other question which I've missed and which you people suddenly remember, maybe it was in pharmacology or in medicine, some of these questions do have an overlap. So please write back to me on the forum or on my email, and I'll try my best to help you. All right, thank you so much.